right, so it is July 9th. It is like the week before things start really happening. And it's the final Friday for, well, at least before the first group takes test. So I took the questions that I got sent to me and I created another 20 question mini test. It seems to be the popular choice rather than me doing PowerPoints. So you guys should be able to see my Slido, yes, I assume. Let's see, wait for a couple of people to maybe join in so that I'm not sitting here by myself. There's Tyler, look at that. He doesn't know how to use aliases yet. All right, we got some more popping in here. We got Renee popping in. So again, like I said, the questions that people sent me, oh, Prison Mike's back. The questions that people sent me, I have taken and added them to the Slido and made a kind of a review test out of it. We'll see how we do here. I'll give you guys a few more seconds to kind of join in. For you guys to just know how much fun my day was today. It was retake day for the bones practical. So that went terrifying for the students that needed to retake. They were literally just trembling in their little bootsies. And I caught Dr. Johnson making a mistake. I can tell you guys, because you guys aren't in the class anymore, and in case you guys want to send him congratulations, Dr. Johnson is unfortunately no longer going to be our anatomy instructor after not much longer. He is relocating to Idaho to be close to family, and he took a pretty nice job at a hospital in Idaho. So seeing a lot more patients than he sees down in Boulder City, first of all, so he's kind of excited for that. He is fantastic, yeah. We're gonna have a hard time replacing him, that's gonna be for sure. The only thing I have to say, is there is absolutely no way they can add anatomy to my workload. That just won't happen. I'm already kind of overloaded. So I'll probably teach for the time being. I'm going to probably finish out. He's still got a little bit of this semester, so I'll probably finish out this semester with them, because that's a lot better than bringing somebody brand new in towards the end of the semester. I can handle teaching the last bit of it, the muscles and that. But he recommended somebody that he used to work with, who has wanted to get into teaching and was interested in teaching specifically anatomy. So he sent the information on to Dr. O'Neill so that Dr. O'Neill can contact her. So maybe that, or maybe, I don't know, Dr. O'Neill or maybe Dr. Sokel, but Mr. McKeever does a little too much at this point, and I can't take another class. If I take another class, I'm pretty confident. So you have to, in order to teach so the way that works at the collegiate level is if you're teaching an associate's program, you need a minimum of a bachelor's, a master's preferred. If you want to teach at a bachelor's program, you need a minimum of a master's and a master's with teaching cert preferred. And then if you're teaching at a doctorate level, you need obviously a doctorate already. And then preferably, if you're going to teach at a doctorate level, you should also have a EDD, which is an educational doctorate. Yeah, I think the one that he mentioned was a TA at anatomy at UNLV. I'm pretty sure she was a DPT student from 2 cohorts after me at UNLV. So she's been in the field for about probably 8 years now. So we'll see. I don't know what the spiel of it will be, but yeah, congratulations to him. He's I think he's moving up towards family because, like 3 kids suddenly made him realize that that's a lot of kids. I don't know. And so his wife might be going a little mad at home. I'm just saying. Because I think he has 3 boys too, doesn't he? If I remember correctly, which I imagine that's. Oh, does he have 1 girl? Okay, then I missed that. I thought it was all 3 boys. I was like, man, if she has all 3 boys to deal with at home, that would definitely be enough to. Oh, that's right. That was the last one was the girl. You're correct. I forgot about that. But still, she has 2 boys that are getting into the ages where they start getting dangerous. And I'm sure that he could use some help. All right, so I got a bunch of people join. Let's Joe, Big Joe. All right, we're gonna start this up and let's take a look and see how this goes, and then we'll review some stuff towards the end here. So we're gonna start the quiz. A lot of questions about wound care, so there'll be quite a few questions about wound care in this one. All right, so we're successfully all over the place. Would anyone want to put money down on any of the answers? So I got no one confident enough to put money down. Money on not pale and shiny. Starbucks. All right, here we go. One of the pains, good, right? Okay. Why would you suspect it would be one of the pains? That's a great way of thinking it, Renee. Why would you suspect it's one of the pains? Do you have an idea? Yeah, the P's are part of arterial insufficiency, right? Right. And the other thing, I'd look at this. Yeah, exactly. There we go, Adrian. That's what I'm going with it. You can't have both minimal and severe. Right? You need skin look good, right? To look pretty and have hair and look everything like that. So definitely the bottom 2 are kind of out. But that's Adrian's got brought up the point that I was going to kind of make. If the question has minimal and severe, your answer is probably one of those, because you can't have a condition where you have both. Really, that's not the way the body works. So in this case, right? Good, yeah, right. That's what I was looking for. I was hoping somebody would say that. And look at that, Adrian gets the gold star for it. And the gold stars are worth nothing. I'm just kidding. So minimal aching pain. So remember, what is it called? So if I've got chronic arterial insufficiency, what's that disorder called that I have? What's the technical term? PAD, good, peripheral artery disease, right? And what's it called when I have severe muscle pain over the calf and lower extremities? Because it comes and goes. Intermittent claudication, good, yeah, right? How do I make it worse for a patient? How would I confirm? How could I make sure that actually is intermittent claudication? What could I do to make it 100% worse? It sounds mean, but it's a way to confirm it. What could I do to the legs? What could I do that would challenge the arteries? Yeah, raise them up. Or increase walking speed too. Good, Erica, right? Doing something. Actually, so all 3 of those are valid answers, right? Because raising them up is the easy one. Increasing walking speed or just making them work harder where the muscles are now challenged and need more blood. And then squeezing them, because squeezing is going to help cut off the blood flow even further, which will make the pain get worse. Right, so all 3 of those are valid answers, but the one your boards are probably going to say is raise them up, because that's how you definitely confirm PAD is lifting the legs up and they get worse. All right, let's go for number 2. There should be two that you can rule out right away. Okay, so which two can I rule out right away because they're basically the same thing? The 3-point patterns. Right, good. And also 3-point equals what type of gait pattern? Three-point is only used for what type of patient? Non-weight bearing. Yeah, right. So when he says maximize weight bearing, that means that those two are both out. So then it just comes down to 2-point or 4-point. And 4-point is going to maximize the weight bearing. Why? Why would yeah, it's the slowest. Good. You're going to spend the most time on that limb with that one, right? Because you've got to think, and so you're going to spend the most time on that limb, right? 2-point would be taught in order to do what specifically with this patient? When would he use 2-point? What would be a good, yeah, okay, canes, good. What would be a good reason you would teach a patient 2-point? It is called cross-country skiing, good, right? Upper extremities to match, good, okay. Give me a reason, something, transition independence, good, okay, we're getting closer. What would be a reason in Nevada that 4-point might get you killed? Think how slow 4-point is. When would using it get you killed? Specifically, yeah, in the crosswalk, yeah, right? Think about that if you had to use 4-point in the crosswalk. You'd get like 1 lane across and dead. So it might be good to teach that for speed is 2-point primarily. Oh, Mr. McKeever question. If you notice, I actually sped the questions up today. I'm being mean. I'm testing Hector here, seeing how he does. He can throw stuff at me. Okay, good. We got, for the most part, we got it down to the two that I would pick. So is it true that CP can either be hyper or hypotonic on either side of the spectrum? What are the two primary types of CP? They're named for the type of the muscles they have. Spastic or flaccid. Right, good. So that's hypotonic or hypertonic. Both hypertonic and hypotonic are dystonic muscles, right? The second one is definite 100% a classic CP. It is caused by an anoxic event, usually at birth, and it's basically the child has a stroke, right? That's really what it comes down to. So the last two would be the ones I would be concerned about, but the answer is, what part of that answer makes that wrong? Progressive, yes. The disease is permanent. You can't undo brain damage yet, maybe in the future. But it is not progressive. It's not going to get worse. They're just not going to get better, right? We maybe improve slightly, but what they got is what they got. it doesn't progress. Okay, good. So we got down to the last two. 50-50 shot there, right? What is Nevada currently? Every 21 days. 7 visits or 21 days. Good, Justin, right? So on the 7th visit or the 21st day, they have to be reevaluated. In that case, would Nevada trump Medicare potentially? Because the answer is 30. Yes. The state trumps Medicare. But let's use, I think, Louisiana as an example. Louisiana is every 20th visit or 60 days. And Medicare says that's too long. That's why Medicare says every 30 days. 20th visit, man, could you imagine that? See a patient 20 visits before they even get looked at again? That's silly to me. Well, hopefully you will soon. All right. Well, so let me ask you something. Are there 2 of those on there that are the same? Which 2? Telephone and distant. Yeah. So it just depends upon your state what they're called. I think in Nevada we use distant. I want to say California is telephone supervision. So those 2 are out. So that leaves us with direct and indirect supervision. What does direct versus indirect supervision mean? First of all, what's direct supervision? Yes, good. Within eyesight, line of sight. Indirect means what? That they're just what? In the building, right? So this may surprise some of you, but Medicare, so what was the key for the direct supervision requirement? Okay, detector's not a problem. At least keep an eye, just keep an eye while we're doing it then. I'm not grading you anyway, so as long as you can see them. What's the key thing that says this has to be direct? Yes, outpatient. What type of Medicare is that? I know I'm going way beyond probably what you guys are thinking right now, but there are 4 main types. What are the 4 main types of Medicare? A, good. Keep going. B, good. C, good. And D, yeah, there we go. Yeah, B is outpatient. Good job, Kelly. B is outpatient. A is inpatient. Very good. And C and D are where we get the prescriptions or the Medicare Advantage plans. So let me ask, and I'll throw it to Jaira here because Jaira seems really up to date on these Medicare plans here. Jaira, what if I'm on Medicare, but my Medicare is provided by Blue Cross Blue Shield? Do I follow Medicare rules or do I follow Blue Cross Blue Shield rules? Okay, good. Good guess. I'm assuming that was a guess, yes? Why? Who's the payer? That's it. The primary payer. Yeah, exactly. Right? That's all it really comes down to. I hate insurance. Yeah. Welcome to my world. Okay, so what if this said inpatient setting, like Kelly said? What's the answer there? Indirect. Good, right? Could it be telephone supervision? Yeah, as long as what? At least in Nevada. Yeah, as long as you've met your 2,000 hours. For now. Again, that's changing, but as long as you've met it now, for now, you can do telephone supervision in the hospital, which is kind of stupid. Because here's a caveat to that. Let's say you're working for Summerlin, right? So Kelly's got a job. Kelly's now working for Summerlin. And she works at the inpatient hospital and the outpatient clinic. If she sees a Medicare patient at the outpatient clinic, she can actually see him with indirect supervision or even telephone supervision. Because the clinic is attached to the hospital, so therefore it falls under Medicare A laws. Really stupid stuff. All right. Woohoo! Good. Does the diagnosis matter? Nope. That's just there to make you go, to make Jaira go, okay, so does Alzheimer's have anything different that I need to worry about? Nope, it doesn't. That's all it's there for. The key thing, patient is wheelchair bound. Where's pressure injury is going to develop? On the butt. One of these answers made me laugh. Good. I'm very glad that nobody put inguinal canal. That would just be, ow. I don't know. I'm like, just even thinking about that. NMES Russian on the inguinal canal, that just sounds like a bad time. I mean, this is Vegas. Maybe that's a good time, but all right. So, what muscle are we stimulating here for foot drop? Anterior tib, right? Where's the anterior tib at? Anterior of the tib. That's what you would think. Yeah. The anterior tib is technically just inferior to the fibular head. It's technically considered the anterior tib because it's on the lateral aspect of the tibia. Right? Because it kind of sits there towards that synostosis. Plenty of shin splints in my life. Exactly, right? So inferior to the intercondylar eminence technically is right, but inferior to the fibular head is more correct. Oh, a couple of you sent me a question about this one. See how many of you get this one right. Woo-hoo! Somebody must touch wound care right. Huh, I've never heard that. Was that from one of the PT final things? I've never heard that one. So alginates.
Alginates, foam, hydrocolloid, hydrogel, film.
Yep, okay.
And I remember C's before G, so hydrocolloid first before hydrogel.
Yeah. Okay, so now that she's gone through that little thing for us, alginates is right, so congratulations to all of you guys. What do we use hydrocolloids primarily for? It does absorb moisture, yeah, right? Okay. They also have something on the back. They're semi what? Semi see-through. Good. Okay, we're getting closer. Semi-permeable, semi-impermeable, actually. Right. So a lot of our hydrocolloids we're going to use on a wound that's in areas where what? Yeah, maybe stage 1, or maybe the one, especially with drainage, or where there's poop and pee. Keep poop and pee out. Why do we use foams? What's good? What are foams good for? Other than drainage, right? Cushion for pressure, good. And then gauze is just our generic use for everything type thing, right? Yeah, and alginates are the seaweed stuff. That's what I always remember with that one. All right. Okay, so I'm going to say one thing. I'm going to rule out case control and case study because they're too what? They're too close to each other. Yeah, they're not exactly the same gyro, but they're too close to each other that really it's not as, because case control takes a little bit of a randomized control trial and applies it, whereas case study is just literally studying somebody. Question said random in it. Very good. I know it should have been easier, but anytime you see something that says considered level 1A, there is typically only one, or well, there's 2 level 1A research types in it. So randomized control trial is one of them. Does anyone know what the other one is? Where they amalgamate information for a bunch of other studies. Might have to assign it one as homework for you guys to go back and look at. Concave analysis, good, yeah. pretty much all your questions are going to be about randomized control trials. I can pretty much guarantee that. Good. No one guessed lysophoresis. I made that one up. All right. So ultrasound. If you have a sound, it is produced by something that is phono. Yes. So with phonophoresis, do you put the medication under the active or the inactive electrode? Trick question. There are no electrodes. Just goes under the ultrasound head. All right. So if phonophoresis is delivery by sound, then I already kind of gave you the trick question. Iontophoresis is delivered by e-stim. How do you know what pad to put the medication on in iontophoresis? What charge the medication is, right? Do you do like charges or opposite charges? Like charges. Good. So if I've got a negative medication like dexamethasone, it goes on the negative pad because it's going to push it into the skin. What is that magical treatment time and intensity for iontophoresis? You guys remember? There's one magical time that we kind of use for all iontophoresis. Close, a little higher. $40 milliamp minutes. Do you remember me briefly talking about that? So if I deliver the medication at 4 milliamps, how long is the patient on the ionto for? Actually, technically, this should be a dot, not a dash. Okay, 10. Why? Well, because it's just math. Right? So that means that if I do 2 milliamps, the patient's on now for how long? 20 minutes. Good. That's literally how hard your questions might be on ionto. So you do have to know the 40 milliamp minutes. That's the magical number. Kind of like 1.8 watts per centimeter squared. Most meds are negative. You're right. Okay, so what's your key thing about this type of debridement that clues you which one you want to do? Life-threatening. Yeah. If it's a life-threatening wound, it's surgical all the way because that stuff's got to come off. Why would a wound, though, why would a pressure injury be life-threatening? What could happen? What are we worried about maybe? Yeah, an infection in there. Yeah, right? So that eschar is just sitting over a giant boil of infection. And so maybe if we do something like autolytic or mechanical, a couple things could happen bad where that infection gets into the bloodstream and the patient goes septic. Surgical is the better option at that point. I'll answer in a second here. I just started the next question, so give me 1 second, Renee. I'll go back to that. Excuse me, I'm sorry. Yay! So Renee quickly asked, what is autolytic debridement? So enzymatic is enzymes. Does anyone remember what autolytic is? Letting it breathe. You let it do its thing. Yeah. Right. You let your own kind of natural enzymes, or also technically even something like meta honey is considered an autolytic debrider because it's a natural type substance. It's not a chemical enzyme. But autolytic basically means you let the body kind of self-prune itself. Good. What part of the occipital lobe processes the right eye? The left lobe. Good. Why? Okay, it's opposite, right? Where does that opposite part occur at? It is usually contralateral to the whole body. Good. But where does the eye switch over happen at? On the optic muscle. So the nerve leaves the eye, goes back over the sella turcica, and there's a little thing there where it desiccates and crosses over. Does anyone remember what that little part where it crosses over is called? The optic chiasma. The optic chiasma. That's where the eye switches from right to left. Okay, good. We're split between the two I would pick. All right, leukemia, malignant neoplasm of what? Or could be malignant. Okay, blood, right? Specifically, what type of blood? White blood cells. Good. Lymphoma. That hopefully you can figure that one out. That's lymphatics, right? Could be lymph fluid, could be lymph vessels, could be lymph nodes, right? Could be any of those. I always hated the term carcinoma because what does really carcinoma mean? Does anyone, if you break that down by using the Latin, what does that literally mean? Yeah, deadly cancer. It's basically a cancer tumor. So it really doesn't break down all that much. But sarcoma is and here's the way I remembered this one when I was going through it. The way that I remembered a sarcoma for this is that if a patient has sarcoidosis, one sec, Dr. Reskin just messaged me. If patient has sarcoidosis, it is a connective tissue disorder, right? And where are you likely, first of all, where are you likely to find carcinomas usually? Where's the most common place to find a carcinoma? Okay, back, right? Good. So carcinoma is typically sarco means, yes, that technically means connective tissue because you have sarcomeres in your muscles as well, right? And the sarcomeres are the parts that hold the muscle together. And I think technically sarco means connective. Let me double check that. I think sarco. I'm now curious. You maybe. It means flesh. That's what it means. Fleshy, meaty. It means hamburger. I could go for a sarco burger right now. All right, 2 of these you should rule out right away. Woohoo! All right, which ones can we rule out right away? I mean, this one's kind of silly, but yeah, the first two, C1 and C3, are way too high up. So if C1 and C2 or C3 are too high up, what's wrong with T2? It's too, yeah, so 3, 4, 5 to stay alive. Yeah, right. Exactly. And the other thing is T2 is just too low, right? Yeah, I mean, yeah, you'd be able to self-feed at that point, but you'd also be able to do just about everything else with your upper extremities, right? What do you need in order to self-feed? What muscle, primarily? Deltoids was ESOH. I don't know what that is. ESOA. Esophagus. Okay, you need esophagus. Good. Okay. Okay, I only get what you get. And then biceps, Hector. Good. Right. You need the delt for a little bit of shoulder flexion. You need the biceps to be able to bring the hand up, right? Because I could have just a tenodesis grip and still feed myself. And I definitely need like C1, C2 for esophageal swallowing. Or actually accessory swallowing more. All right, good. All right. What end feel for elbow? Extension. Harder, bony, good. What about for wrist and ankle dorsiflexion? Firm? Or what's the other term for that? It seems silly, but the other term is just simply muscular and feel. Just means that the tendons are tight. Firm or muscular. This is the only one that would be soft. Where else could I get some soft end feels? Elbow flexion, good. Hip flexion. What goes along with hip flexion? What's hip flexion just in the opposite direction? Instead of picking the leg up, taking the body down. Trunk flexion. Right, same similar motion. right? So hip flexion, bring the hip up, trunk flexion, bring the body down. What about something like shoulder adduction? Would that technically be a soft end feel? So bringing the arm back into the body. Yeah, I mean, technically. I mean, maybe Renee might be a little firm end feel. Abduction would definitely be firm. Adduction, adduction, would be a soft, right? What about the neck? Where could we get soft end feel at the neck? Okay. Maybe lateral. Okay, if you got some pretty loose neck. Neck extension, maybe. Okay, yeah. If you had some motion, right? Yeah. What other end feel could you get at the neck extension? There's one other thing you could get for neck extension. You theoretically could get what? If you don't have a lot of meat back there. Could you get bony? Yeah, hard. Why? From C7. Like, yeah, if you've got somebody that's got really kind of big kind of bony vertebrae and it's really tiny, sometimes if you go way back, especially if their neck's really loose, you can get a little bit of a kind of hard end feel back there. Not very often. I've had like one patient that was that flexible before. And neck rotation would be my skill up, yeah. For me, on one side, it'd be hard. Abnormally hard. Okay, so key thing, technically, they would definitely be non-compliant. But the better answer there would be malingering. So what this is basically saying is the patient keeps giving you bull crap. Yeah, it is kind of like a pun, right? In this case, the patient's basically giving you a bunch of bull crap, and they're lingering, bad, hanging around, right? Or mal, technically lingering, right? You can't have two L's though. Mal meaning bad. Technically, it'd be a non-compliant patient as well, probably. But this would be the patient that keeps coming to therapy and, you know, you're testing them and you know they've got more muscle strength than they're giving you, but man, they're faking it really good. And, you know, they walk into therapy and they're on their walker and they're hobbling all around. And then as soon as they get out the front door of therapy, they fold that walker up and walk right to their car just fine. Trying out for a Grammy, yeah, exactly. Or an Emmy, one of the two. Grammy's music, isn't it? Maybe I'm wrong. I don't know. I don't watch those awards. Well, they could be trying out for a Grammy too with singing with their pain. Who knows? Okay, so if we know what a compliant, non-compliant is. We just kind of covered malingering. What's transference? It's not probably one you're going to get on your boards. I just threw that on there. What's a transference patient? Transference is going to be when Adrian goes and works at a pediatrics clinic, and he's paying so much good attention to little Jimmy, who's getting so much better under his care, that his mom starts bringing him presents. Maybe she brings him lunch one day. And then the next day, she's like, you know, maybe you could come see him at home for his next visit, and I'll make you lunch. And then Adrian shows up, and then like 3 visits later, the mom shows up and she's like all done up to the nines, like she's going out to the club to visit and hanging out with Adrian in the back while Adrian's doing treatments, and she's just laughing at everything he says. That's a transference patient. That's where the patient kind of, it's not necessarily development of feelings, although the patient feels it like it's development of feelings, that they're falling in love with you. Yeah. What it really is Adrian may be the only one paying attention to little Jimmy. Right. And it can happen to guys too, ladies. So it's not just limited to you ladies trying to do it to us. It can happen to guys as well. So, guy starts kind of going, thinking that Renee, Renee's been the only therapist seeing him for the whole time he's been coming. So there must be a reason that Renee has been the only one treating him, right? It couldn't just be that he gets put on her schedule. It's got to be something else. Renee must be requesting him. And then, that's when he makes that one move in the middle of the therapy session. And Renee hits him with the stool. Good job. Anytime you see most safe and assisted device, it's parallel bars. Does the diagnosis matter for this one again? Nope. That's all there because right now, Kelly's looking at this one and going, okay, so it's a left hemispherical stroke. That means the right side's affected. Okay, good. And it looks like they've got severe apraxia, so that's partial with the motor plan. And then she's like, oh, God dang it. It just says, yep, it's safe. And she gets to the last part and it says safe assistive device. And she's like, God damn it. I didn't have to think of all that. Okay, I asked a similar question to this. Yep. All right, so good. Right, private cohort room. Why? Why would you want a TBI in a private cohort room? Less distraction, right? I like lay distraction. Lay distraction. Okay. Now let's take it a little step further. And now let's say that the question had this in it. What is that? What is the LCFS? An acronym. Good. I'm glad. Got that much, Jira. Good, right? Who developed the LCFS? Low carbon fuel standard. Who developed the LCFS? Who develops all our neuro stuff? RLA, good, right? Ranchos Los Amigos. So LCFS is that scale that goes from what to what? Do you remember? How many levels are there? Not 3 to 20. That is the perceived exertion. Actually, 3 to 22, I think, is perceived exertion. No. Goes from 1 to 8. There we go. Good. 1 to 8. Right? So 1, do you remember what level 1 is? No response. Yeah, not functional. Good. 2, generalized response. 3 is localized response. That's right. Okay. All right, so we have those 3. Okay, 4 is, okay, we got 4, we got agitated, right? Good. What type of agitated, though? Confused and agitated. Good. Not Confucius, confused and agitated. Okay. 5 is what? We keep which part? Okay, good. We keep it. We've got inappropriate. We also keep what? Confused. Good. In-app. I'm just going to put in-app. Now 6, we get to what? 6, we still keep confused, but now what happens? They're appropriate. Good. Now they're appropriate. And 7, we get rid of, well, get close. We get purposeful now. And appropriate. Right? I'm sorry, no. You're correct. Automatic. You're right. You're right. I would jump ahead of 1. You're right. Auto and appropriate. You are correct. I was jumping ahead. I always get those 2 messed up. Even at my state. So you're correct. Smack my fingers. All right. So which level there, looking at those, would be best? From what and under would you treat in a private room? Five and under. Good. Yeah, that's a good rule of thumb. So pretty much from there up is probably better in a private room. Why would you not want to take a confused, inappropriate patient up to a therapy gym? It's a loss. That's, yeah, I mean, they might hurt themselves or someone else. Yeah, that's the main idea. But Kelly's pretty much right. It's a lawsuit waiting to happen, right? You turn your back on the patient and they're groping some other patient or something to that effect, or they're groping you. That actually brings up, I mean, it's kind of a good question for the clinic as well. If you have somebody that's LCFS 5 and they do grope you, are they actually doing that? Not really. No and yes, right, Kelly? Yeah, so they may have, you're right. So all of, I'm not gonna say all of us, that would sound kind of creepy, but we all have the idea that, I'm gonna use this as an example. All of us have had that time where we've been at the store and we've wanted to reach across and smack somebody in the store, right? But the frontal lobe says, Kelly's at the store and somebody's taking up time at the checkout line. She just wants to reach out and just smack somebody with a box of cereal. Her frontal lobe says, no, that's a bad idea. And so she just sits there and grumbles, right? But the patient that's confused and inappropriate is going to not only smack the person with the cereal, but they're also going to pick up a twisted tea can and smack them upside the head as well. No, I saw the twisted tea thing. Okay. From 6 down, now we can start going to the gym. All right, Gyra saw it. Keep it twisted. All right, 2 more. Excuse me. All right. So excessive warmth? Yeah. What is our key phrase here that tells you what the answer is to this one? Yeah, the strong ache. Right? And a strong ache is bone. And not only that, but the number one thing we can irritate with an ultrasound is the periosteum because of the cavitation, right? How do we keep from irritating the periosteum of bones with ultrasound? What's the easiest way we can do that? Gel, good. And then what else? Keep the head moving. If you're like making little itsy bitsy circles, right? You're keeping that ultrasound in that little itsy bitsy spot, and that can really irritate the periosteum of the nerve or of the bone. Okay, let's change this. What would I put if it was irritating nerve fibers? Sharp. Good. What else? Maybe. Loss of feeling. Okay. Stinging or tingling. That would be nerve as well. Okay. What about for a muscle? Well, I could keep the same question and change one word. What word could I change? I'm going to keep ache and change the word before it. What kind of ache? Yeah, dull ache. There you go. Yeah. Typically, dull ache is more muscular. And honestly, I don't know what a blood vessel irritation would feel like. That's bloody strange. I'm assuming it would feel kind of throbbing, maybe. I don't know if there's such a thing as blood vessel irritate. I guess theoretically, because it's smooth muscle, you could irritate it with ultrasound, but I don't know. I don't think I've ever done that. I've definitely irritated periosteal fibers before. All right, one more. Come on. You got this. Another wound care one. This should be a gimme. Now use those P's and look for that peri wound. I just gave you the answer. Well-measured edges is the key there. Well-measured edges means what? What does that term or that phrase literally mean? Yeah, it's regular. Right? We know that the main thing with venous stasis ulcers is they are zombie bites. Yes. They're zombie bites. All right. So actually, we did not do too bad. Screen here. Where's my link to this one? There we go. All right. So good questions. Did you like that one? Not bad. Right. There was quite a few wound questions that people sent me, and most of them I answered. How many of you guys have tried one of the PT final tests? I just totally shook my whole, look at that, I can shake my whole desk. Okay, so Jairus tried one. What do you guys think about them? They're meant for TPT. Yeah, I need to talk to Dr. Crane a little bit about those. And I think he means well, but I specifically saw a couple questions that people sent me where it was talking about you doing an evaluation. And I thought about it. I'm like, could I imagine if I said that to Dr. Ovreskin, what her head would look like? Right? How's it an assistant? But just imagine if Dr. Ovreskin read one of those questions that said, you're evaluating a patient. Her hair would stand out in the end and her head would spin around in circles. Oh, come on, you guys know it. We actually went over one of those questions with her today, and it was her first thing. I'm like, okay, forget the evaluation. Let's just talk about the question a second. He means well. I think he's still got to develop a little bit. The rest of the program I'm really enjoying. I've actually gone through a bunch of the podcasts. The podcasts are really good. But yeah, the tests, he's got to work a little bit on those testing things. I'm just saying. And I get that probably because most of his instructors are DPT instructors anyway. So I understand that. Maybe he just needs to hire a very experienced PTA instructor that really has been in the field of teaching for at least 6 years, working in PTAs. I don't know. No, I'm okay. I don't need another job. No more jobs. All right, guys, you're down to the wire at this point. I know nerves are high. At this point, you should be trying at least to get a PEAT done like soon, so we know where you are if you haven't done one yet. So we can kind of have a little bit of a come to Jesus moment if you haven't done one yet. The PEATs are out there. You should have pretty much received keys for that at this point from Dr. O'Neill. I'm assuming. I don't have anything to do with ordering them, so I'm assuming she sent those out. I had to fix a little bit. I wasn't trying to minimize Zoom. Why did you pop up like that? But like I said, you're kind of at the end of the line here. So this is the point where, I'm not going to tell anyone specifically to reschedule. It's not my job. We have to bring masks, but are they going to actually let us use our own if we can't even bring in our own pencil? As far as I know, as long as it's a cloth mask, you're fine, Renee. They may ask to see the back of the mask, though. They just actually had somebody try that in San Diego, and where the person was wearing a mask, and underneath the mask, they had a crib sheet. I mean, I got to give him, Kelly, it's a smart idea, right? My thought process is on this, what if, it's partially smart too. I mean, they're trying to get away with something. So Erica said they made him show the front and back. Good. It's usually all one big room, Renee, just with lots of seats in it. And then there are cubicles, and the walls are about yay high, and they come out to just beyond your chair. So you literally are slid in a little bit. And there are headphones, much like these, except they're the shooting headphones that block sound out. These actually have sound. I'm using these because I found that it doesn't echo them sometimes for you guys. Headphones are trash. Yeah, they're not that great, but at least they block something out. Yeah, I think you can bring regular old style foam earplugs. So you are allowed to leave whenever you need to, but so you're not allowed to stand up and act out your gate. No, you gotta kind of what I did with my gate stuff is I slid in under the desk and was doing my gate stuff under the desk. Yeah, the chair you can move around. You just kind of gotta watch that you're not disturbing somebody else. So Renee's asked if you can leave after each section. You can. So remember that the only scheduled break you have, you don't have to wait for anyone else. You're just on your own time as soon as you go in there, Renee. So as soon as you go in there and you click start, it's on your time. You don't have to wait if Hector's in the room with you. You don't have to wait till he has break. But your only scheduled break is after the second section. That's a scheduled 15-minute that doesn't count against your time. But let's say after section 1, you had Starbucks plus a whole bottle of Voss water before going in, and you have to pee. So Eric, I thought you could do it during the sample stuff, but I could be wrong. Where they have a little this is how it works demo. That was when I did my brain dump, but I don't know. It might depend on the testing center, yeah. But again, if you at the end of the first section and you have to pee, it's probably better to get up and go pee and lose those 5 minutes going pee than it is to sit there crossing your legs and then get what was that called that you could get by holding in your pee? What's that condition called? UTI. Okay, yeah, you could get that. What's it called when you start sweating and your blood pressure? Autonomic dysreflexia. There you go. Good. AD. Or hyperreflexia, T6. Good. It can happen for normal people too. I've literally done that while driving where I think I've thrown myself into autonomic dysreflexia because I'm not stopping until I need gas. I think that's a guy thing. But that's kind of where we're at. Is everyone else feeling okay? I mean, other than terrified at this point, there's not much else you can expect your glasses. Well, I know why that is. Because last year, so before COVID, somebody tried to go in with the Google glasses. Yep. But I don't understand how you couldn't see that they're the Google glasses. Don't the Google glasses have that little flip down thing that comes down across the eye? I thought, who would try to get away with that? Yeah, they have a huge chunk of glass or something in the front, right? I'm like, who would try to get, I guess, yeah, I went in running shorts and a t-shirt, but that's also because I sweat profusely and they're like, it's really cold there. And I got it there. I'm like, this is not cold. Cargo shorts gang, yeah. Mr. McKeever has hyperhidrosis, I think. I can't handle it. I sweat way too much. Just make sure, Jaira, I don't know, cargo shorts might not be a good idea because if you wear too much cargo shorts, then you're going to have to have your pockets checked. So I think that's why I remember wearing basketball shorts. Yeah, it's because I was like, there are no pockets in these, so it made it easy. And you do get a locker to lock your stuff up. So it's not like you just have to leave it in some little cubby. It's kind of like going to the water park where you rent the locker or going down to Splash Mountain or something like that. Except you don't, I guess you technically did pay for the locker just the same. Although some of you may want to go to Splash Mountain after leaving the test. I can't judge either way. I sadly went straight from my test to a 10-hour shift, so that was loads of fun. I didn't get my socks checked, but I could see that if they're suspicious of you, I guess they could. Justin, there's one right across the road. I'm not even joking. There's a Starbucks on one side and a bar on the other. Both at the same time. You guys can do this. I have faith in you. 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 And you guys, you've been through a lot. You guys are the true pandemic group, right? We can't even think about what life was like BC. or what I call before COVID. We are now in an AC world. We're in massage on YouTube groups. Yeah, I've gotta teach that next 2 weeks. Yeah. Anyway, I want to get into that. I'll make Mr. McKeever cry. So there, how many ever you tested? There are also 4 retesters that you'll see from previous cohorts. So if you see them, give them a high five and tell them they can do it too, that aren't part of your group. You should be able to see them because they'll probably look more terrified than you. There's quite a few testers this time, not only from us, but also from Carrington and from CSN. So should be pretty busy. Is there any questions that I can answer? And again, if I will hold another session next Friday for anyone who's still not tested yet. So I'm not abandoning you if you're like testing in a week or so. So you still have time if you need to hit anything with me. I'm not going away. I don't get to go away. They haven't fired me yet. Yeah, I had my motivational playlist, and then it was funny, Eric. I got about a block away from the testing center, and Drowning Pool Bodies came on. I was like, I don't think this is appropriate. This is not good. That should be after leaving the test. And then I walked out and I put my iPad back on, and I swear. Well, I have to say the iPod had something, or my iPhone had something. I plugged it in, I put it on, and the first song that played after the test was Metallica, Nothing Else Matters. Yeah. Good stuff, iPhone. Get out of my head. It's like your iPhone's listening to you, and at least it wasn't something, like that could be worse. I mean, it could have played plenty of worse songs on my iPhone. Trust me. All right, guys. I'm gonna hang out here if anyone wants to talk or meet with me here or needs to ask any questions. But otherwise, you guys got it. I'll post the link on the video once I post it up here, once I encode it. Otherwise, you're out. Thank you, guys. Have a good rest of your day. Go get something to eat. Now stop recording.